Hello, everybody, and welcome to the 11:15 session where we're going to be looking at the future of employer-funded healthcare. And I'm hoping that during this session, we're going to get lots of questions from all of you, maybe get some discussion going. We've got the option of both using Slido, so if you want to post questions on Slido, please do. It'll come up on the screen for the panel to see. But we've also got a roving mic in this room, and we might just be small enough as a room where that might be quite nice to get some chatting going. So whatever works best for you for asking questions of our fantastic panel that we've got here today, we will go with that. So firstly, I would like to say well done on picking this session. You've clearly got your finger on the pulse of what's changing very rapidly and is going to be quite high on your agendas, I think, for 2024 and beyond. And I'd also like to say thank you to our strategic partner, Peppy, who are joining us on the panel today. So it's probably a good time to introduce the panel. So sitting right next to me is Dr. Marija Lepore, who's co-CEO and co-founder at Peppy. Next to her, we have Anne Cotgreave, who is Head of Reward and Benefits UK at the law firm Clifford Chance. And then on the end, we have Samantha Sargent, who's Director of International Benefits at Microsoft. So a nice spread of expertise on this panel to have a chat about how things are shifting, how things are changing. So I'm going to come to you, and Anna and Samantha. I've posed the same question to both of you as a bit of an introduction to the topic and to your organizations. And I want, as you introduce yourselves, to share what are the three key headline areas that you're looking at, in your case, Clifford Chance and Sam with Microsoft, with regarding your employer-funded healthcare and medical inflation.
Sure, thanks Debbie. So my name's Anna Cotgreave. I'm Head of Reward and Benefits UK for global law firm Clifford Chance, and we have about 2,000 people in the UK who are on our private medical scheme. So we have a number of issues we are trying to look at. One of those, to mitigate some of the costs, we want to signpost our employees to all the support that's out there so that perhaps the PMI isn't the first port of call, because we do have a breadth of well-being and healthcare support. The other thing we try and do is implement preventative healthcare measures, and there's various ways we can do that. One example being through our health screening and some of the advanced screening we now offer through that. And finally, it is managing expectations. That's both within the business and also with our employees. So I guess managing expectations of finance in terms of increasing costs, but also our employees that PMI can be the first port of call, but doesn't always need to be and isn't always the best place to support people. For example, in an emergency, your local A&E is a far better place to support you. So,
Wonderful, thank you, Anna. I'm Samantha. I oversee Microsoft, and just to kind of give you an idea of our base, we have 100 countries outside of the US with roughly around 300,000 employees and their families that offer unique employer healthcare programs. And so there's a lot that we're thinking about that, in addition to what Anna shared. For us, it's looking at multinational strategies and scale across multiple countries, specifically with captive. We're also thinking a lot about data and AI. So you heard Microsoft mentioned a couple of times in there, it's at the forefront for us. Everything from how are we using data from our providers to tell the story of what's going on with the healthcare programs, specifically to our partners, and then how do we layer in AI when employee experience is at the forefront? So how do we build the story around healthcare, EAP programs, other supplementary programs, so that we're not going directly to healthcare all the time or directly into our private medical programs, but also how do we layer in AI data on top of what we're getting from the suppliers to really drive home a narrative and a storytelling that we've yet to do. So thinking broadly, thinking forward, but also thinking with a lot of scale. In the UK specifically, we have 5,000 people. So I will be coming at this from a little bit of a UK-specific lens, but also thinking multinational and how are we doing this work at scale across other countries.
Thank you. So Marija, you work with a lot of clients, so you have, I'm guessing, a bit of a view across the market. What are the three headline areas that you're seeing that employers are really rethinking linked to medical inflation?
Yeah, I mean, we obviously work with a really wide range of organizations. We also partner with the insurance sector, so, and very conscious of being part of the healthcare ecosystem, obviously in other markets as well, but particularly in the UK where it's shifting. And I think when you think one of the things that I spend a lot of time thinking about is shifting workforce, how it looks, but also what it needs. And that's starting to play out in the market today. So if we think about medical inflation, it consists, in my mind, of three different things. I mean, one, the same thing's costing more. I mean, we all know we've got core inflation. We also have a talent shortage when it comes to healthcare professionals. And I think we're starting to pick up a little bit that actually now private care providers are having to pay more for some of those healthcare professionals to be able to fuel the demand. Secondly, what the populations are asking for, and we've seen a massive behavior change in that, particularly, the NHS is struggling, we know, with wait lists, access, and so on. As both Sam and Anna said, people are shifting to their PMI often as a first port of call, not necessarily the most appropriate port of call, but that's definitely driving volume, away from the NHS and into employer-funded healthcare. Secondly, it's a sort of behavioral change, I think, that we're seeing after COVID. I mean, obviously, we've got aging a population who has more health needs, but also amongst all demographics, particularly younger demographics, more willingness to seek help for mental health, for example. So demand is going up, which, if you look at it over time. And then finally, I mentioned the aging population, but that, the population itself is shifting, and we'll see a massive shift in the next couple of years, whereas people are, there are more older people in the workforce with naturally higher health needs. So all of these things are sort of underlying drivers of medical inflation, some of them temporary, some of them which we're just going to see grow over time.
So it's interesting, I've got two questions already popping up on Slido, and they actually play very well to the first question that we were discussing, because I want to challenge the title of this particular session. We've been deliberately a little bit controversial by saying medical inflation being a game changer, and I want to go, is that really where the game changer is? And if I can come to you, Anna, is it all just about the inflation, medical inflation?
No, and it's interesting just reading the questions. So we've always had medical inflation, and I've been with Clifford Chance for 13 years, and the year-on-year cost, it's always been there. So it's not something that is necessarily that new to us as an organisation. And so it probably isn't a game changer, but the question, one of them references new technology and treatment. And it's interesting because we have had new cancer drugs, for example, come onto the market, and there was a real fear that this was going to, if we were going to include these, our scheme would then become financially untenable because they'd be so expensive. The reality is we haven't seen that through our scheme. So, I mean, yes, they've increased the cost, and yes, we've added new things. For example, we've added fertility cover to our PMI plan, and that has increased the cost, but not as much as the fear around increasing the cost. So I don't necessarily think it's just inflation that's part of it, but it's not a game changer in that it's not that new.
Yeah, and Marigina, would you agree with that, building on your answer that you said earlier? How is it shifting?
Yeah, I mean, I think scope of what employees are asking for is obviously expanding. And I saw the question also on technology. I mean, that's certainly the business that we're in, is to try and bring down the cost of servicing some of that demand, which, ultimately maybe is not being handled well by other providers and so on. So there are things in the wings coming to the fore to bring down that cost, but certainly I think as, again, the population's changing, the needs are changing, other traditional providers or, infrastructure isn't able to serve that, there is pressure on employers, and that's something we hear a lot. Our employees are asking for X, Y, and Z.
So in terms of rethinking insurances and the linked benefits, that ecosystem that's been evolving in recent years, is that pushing up costs? Is that likely to pull down costs? what kind of experience are we going to see around that? Sam, can I come to you on that question?
Yeah, absolutely. And I think, can I just
Yeah,
touch
of
on the
course.
last question slightly? I agree with them. I don't think it's a game changer. But I think this year, with all of the other variables that were playing into the environment that our companies and our finance partners were having to handle, whether it's reduction in force, whether it's inflation in other areas, medical was one more variable on the table that made a hard conversation even harder. And so remembering where our partners are at and kind of meeting them where they're at and having to have these conversations with them 2 months before budgeting to say, hey, actually, we're up 40% and we can't say no. So how do we have a mitigation conversation right here? When I think about the ecosystem and technology, this is actually one that it gives me a lot of passion. I don't think we're there yet. I do think with capability of tying together all of the different ecosystem aspects that come with benefits, so app after app after app, or experience after experience after experience that feel very individual right now, when we can, fingers crossed, create an experience that brings all of that together for employees where they don't have to go to separate apps, or they can ask a question around, here's what I'm feeling, or here's what I'm looking for, whether that's a menopause journey or it's, I don't know, a cancer care journey. They're not looking at those individual aspects. So I do think that will play into cost savings because we will be sharing with our employees a way to mitigate this that isn't directly to private or isn't directly to your doctor. I don't think we're there yet. I think we would love to be, but we're at a very individual experience right now. I'm intrigued to see what comes in the next 12 to 18 months around here. And I think a lot of it is going to happen with our partners, and I think a lot of it is going to have to be driven by us to hold our suppliers accountable to be part of this technology journey with us.
So you mentioned what you might call friction points, this white noise fire hose of all these online GPs and a myriad of different fantastic services, which is great to see. Because if you go back 10, 15, 20 years, they weren't there. You just wrote insurance, you had so many lives on the book, and that was done. It's now looking very different, and I've done lots of off-the-record calls with insurers in the last few weeks. They're also looking at all of this. What are some of the things that gives you hope? And Anna, I want to come to you because you touched on prevention, and I can see there's a question there talking about health checks. And you've done this quite successfully using some of those other services. Can you tell us a bit more about that?
Sure. So we've always offered health screenings to employees. But a few years ago, we made a conscious decision to make that more targeted in what we were offering, particularly and comprehensive too. So if there were a family history of any types of cancer, then there'd be a much more thorough screening. It wasn't just age dependent, it was dependent on your family history. And we have picked up a number of employees have had cancer, and we've picked it up really early, different types of cancer. And I can't say that, I don't know for sure there's a direct correlation between that and our PMI costs, but it feels like it's now filtering through, that we're not having so many expensive claims coming through in the way that we used to. And I don't think that's because the technology's necessarily changed, because cancer treatment is as expensive as ever. It feels to me, knowing that we're picking up these claims earlier, means that they're not quite so expensive. And obviously, the best scenario is that they have a better outcome for the employee too. So I think, it is positive.
I'm loving the questions coming through.
So
it's
many.
Completely messing up my pre-prep questions. However, I'd rather actually answer the questions that we want from our delegates. But there's a question that's risen nicely to the top that I want to come to you, Maritula, on this, because it's one that we've been discussing quite a bit. Is the rise of digital GP services pushing up costs as they refer employees to PMI instead of the NHS? Of course, you can also, online GPs can refer to, can come through your group income protection elsewhere. But what's happening on the costs?
So in short, yes, they are pushing up costs. We know they are today. Because of something you mentioned. I mean, ultimately, digital GPs, more people having access to them is a good thing, right? Bringing down that threshold for people to seek first care is a good thing. But if what the toolkit that they have is simply to refer into a specialist, you naturally get a lot of people siphoning through. And I know a lot of our insurance partners are really, really focused on this. So it's a lot of the work that's happening now is around those pathways leading up to that. How can you give information? Some of these things are avoidable interactions. How can you give people information and access to support in different ways so that they don't need to go to the GPs and end up directing up to a specialist? The use. It's been a long time since the insurance companies have done things like have musculoskeletal triage with physios, or mental health triage calls and so on. That's a sort of very basic way. There is a lot of opportunity to do a lot more there to give people really good service and care, or recognizing that, of course, there will always be a cohort of people who do need that digital GP service and do need that specialist care referral. It's about making sure that it's happening for the right people and not unnecessarily. But I think this is a sort of the flip side of the technology, right? It's been wonderful. And as from a user experience, of course, we all value, being able to have that GP access compared to especially going in person or, even booking sometimes an in-person GP appointment. But there is this sort of, again, part of the behavior change that's been driven of that is kind of causing this surge now. I can see a question.
Yes, I'm going to come to the question. I think, Evie, if you got the microphone, there's a lady just over here with the question. Or a different viewpoint, because I've got a different viewpoint as well. I think we can get some debate going.
Is this on? Yes. Sorry, it is actually a different viewpoint. So, Dana Citron, I worked for DHL, for the insurance captive, and I worked in the insurance industry for 15 years. And we actually see, because even going back 10 years ago, I was working in the Middle East, and we were trying to put in telehealth because it does help to manage costs. Because we see people get picked up earlier, and same thing in the UK. What you have with a part of healthcare is you have supplier-induced demand. So, as said, you need to educate the providers about where they should be pushing people. But that is what the insurance industry is doing, because we know it's a great cost management tool. 100%. Plus, it saves HR savings of people being out from work, et cetera.
Absolutely. Can I ask you a question on that? Because I was talking to a group risk provider yesterday, and on the PMI side, I can absolutely see it pushing up costs. But they were saying from a group risk point of view, that early intervention, they're predicting dropping in costs. So are you talking long-term insurance, or are you talking about the short-term PMI?
Well, when you're talking about medical insurance, it's always a long-term game. You can't think about it in the short term. It's not what happens in year one. And it also depends on how many people. So we do all the underwriting ourselves. It's looking at what is the population doing. So if we're able to catch someone earlier, then yes, we know that there's all those benefits. Not having someone be out of work, also not going to a doctor and being able to have that conversation. It's quick access. It's catching things early. So we talk about, in insurance, like you said, it used to be paying claims 20 years ago. It's now become across the world about managing health. Yeah. And this is a part of it, and it goes back to managing medical trend.
Yeah, no, I agree with you, Dana. And I think so my view is it's like a transient thing that's happening right now until we settle into a new, better, a new state, hopefully more stable state.
I wonder what that will look like. So, but while we go through this transient stage, Sam, I want to come to you, because we talk about about to providers, and they're different types of providers, but it's one big ecosystem. How do you talk about costs? How do you talk about that time to come up with a solution for higher than expected increases that we might be facing now, but could be different down the line?
Yeah, absolutely. It's a different conversation per provider, and it's a different conversation per country. So I will focus this a little bit on how we manage it in the UK, because I think that's most relevant here. With the captive, it's fabulous because we have a different relationship. We're self-insured. The negotiation there is a different ballgame. We have a couple of tactics. We do one-on-one conversations. We meet quarterly. We ask for data. We really do try to hold our insurers accountable to let us know what's going on. I really appreciated your point around thinking about that long-term game and using the data that you're getting on claims to help build the story. And so I talked about previously, like bringing along your finance partners. You don't want to come at them with 45% increase 2 months out of budgeting. You want to be able to tell the story of why. And so having those conversations and then bringing everybody to the table, we do in the UK bring all of our benefit suppliers together. We talk about costs. We talk about how things are going. We talk about what is the ecosystem. Sometimes it's hard conversations, but our roles up here are to make sure that we are driving forward the best benefit programs for the least amount of cost, and that's what we do. So it's having individual conversations, it's holding them accountable, it's doing and using data-driven decisions, but it's also getting everybody at the same table to make sure you're working toward the same goals. But it is different country by country, and so you have to be adaptable if you're going to look at it from a multinational strategy.
And I want to we've got some great questions which I'll come back to, but I want to just touch on something that's unique to the UK, which is the NHS. And I saw a question earlier asking about using employer-funded healthcare along the side of the NHS. But taking even a step back from that with the government viewpoints, Marigila, you've been working quite closely or sitting in on various discussions in government about occupational health, and we had the consultation that closed in October.
Yeah.
Any insights of what, well, who knows who's going to be in power next year, but assuming for the moment of what the thinking is currently around employer-funded healthcare?
And unfortunately, we didn't see anything in the autumn statement on this topic, but I know there was a lot of anticipation around it. Look, I mean, historically, the government thinks of healthcare through the Department of Health and Social Care, and that's the healthcare budget and provision. And I think what we've seen over the last few years is actually it going up a level onto the Treasury's radar, and then looking at it across a cross-departmental point of view, including the Department for Work and Pensions. So I've sat in on various roundtables hosted by various government departments and others, other influencers, where there's increased just, and I do think this is a change, from a government point of view, just recognition of the role that business plays in looking after our society's health. And simply acknowledging that, which seems like probably a trivial thing for all the people in this room, because you all know what you do for your organizations. That's actually a non-trivial thing, I think, in terms of government policy, which has always been sort of, we're the NHS and everything else is icing on the cake. Actually, no, business does contribute a lot already and plays a significant role, especially in this context of, trying to get people into work and keep them in work for as long as they want to and are able to, which is very high, increasingly high on the government agenda, particularly with over 50s and so on.
And I think that's probably where it will be, because if you're not in work already, the employer doesn't access you. But what does that future look like when you've got more people in the workplace who are living with cancer or disability or musculoskeletal, and that is going to rely on employers looking at their job designs and what skills they need and all those things that aren't necessarily to do with insurance, but actually will keep people working longer, which is better for our well-being, as we know. So that takes me to a completely different question. And we've got one asking about the C-suite. So this is interesting that this is coming up, because for a long time, PMI very much was an exec perk.
Yeah.
And we haven't pre-discussed this question, but I'm hoping that maybe Anna or Sam can pick this one up. Do you think that funded medical insurance will return to a C-suite benefit due to the cost?
I would like to think not. I think the way, because I'm only speaking from the Clifford Chance perspective here, but I think this will be seen elsewhere, that there is a greater level of equality between employees. So I think that it would be quite a big thing to remove it, especially in the context of what's happening in the NHS. I think it'd be quite a difficult decision to make, to move any cover. There might be changes made to the way a cover is structured to manage costs, but it wouldn't necessarily be removing it from anyone. But it might be where you've employer funded for families, that part might be removed, for example. But I don't think it would be taken away from employees, because there's a kind of certain level of reliance on it now as well, if you'd agree.
I completely agree. I think, well, at least for us, a couple of things. Inclusion. We're not thinking about benefits in that way anymore. In fact, we're unwinding this in a lot of countries that still have it. I think there's smarter conversations and better mitigation strategies than pushing this into a C-suite benefit. So fully aligned. Yeah.
And yeah, just in our research, what you're seeing more is different levels of PMI or a simpler version of PMI, but employers are talking about equality, fairness, quite commonly. So that probably leads neatly onto the question that's now come to the top. With newer benefits becoming more commonplace, are you considering changing any of the traditional elements of PMI? Or I think maybe the insurance itself. Okay, Sam.
Well, no. I think it's a wonderful question, and you had a great answer. So go.
Oh, well, I was only going to link it to there's another question as well about enhancing what you offer and how can you mitigate that against the rising costs. So I guess the questions are moving, but I think it's kind of linked in the sense that you haven't got to take away elements, but there are elements that employees are using less often because their needs are changing. But you can enhance your cover without adding so much to the cost. An example would be for us where we added cover for gender dysphoria, and we didn't include top surgery as part of that. And then we realised, we've worked with our LGBT plus network, we realised that was a big omission on our part, and we've enhanced our cover since to include top surgery. And in that time, we've had just one employee have the top surgery. But that has had such a positive knock-on effect from just that. So the cost is relatively small, but for a huge amount of, I guess it's uplifting for everyone who's been involved. And the employee who had the surgery has been very vocal about it. It's been, so sometimes you haven't got to spend a lot of money to get a huge knock-on effect, positive effect. Sorry, no, that's all I was going to say.
No, I think that's great. If I can just build off that slightly. There's a thought for me here around targeted prevention. So we're bringing in really cool things. We're bringing in menopause journeys. We're bringing in fertility journeys. We're bringing in all kinds of these different things that feel kind of new right now. But how are we linking that back to insurance? How are we linking that back to the claims that we're getting? How are we thinking about bringing forward really what the employees need? Are we asking the right questions? What is the value? And so I really loved is you have one claim, but that claim is such a huge value story. And so how are we having those weighted conversations? And how are we putting the employee's perspective in front of the data to tell that bigger story? I appreciate that question because I think we're at the very beginning of what those conversations become. And it's just kind of a neat place to be. And so I'll be excited to hear what comes out of some of the other companies, what's coming out of REBA with some of the studies here. I think we'll learn a lot.
And I think this probably is a good time to bring you in, Marija, because I know you've been looking at this ecosystem and this complexity. And it used to be, felt quite simple before: PMI, group income protection, life assurance, critical illness, and then some other add-ons. And yet we're talking now about how do you even work out which online GP service you offer to your employees when there's 6 different options, et cetera, et cetera. How do you think the market might change in just getting people through this maze of options?
Yeah, and I think I agree with you, Sam, that we're right at the beginning, and what that's resulting in is people not knowing what their options are, how to navigate around them, and the data being really fragmented. I was hearing from an NHS GP yesterday. She's got a cancer patient. She is trying to help them, but part of the care is private, part of it's NHS, part of it's happening all over the place. She's like, I cannot help this patient because I don't know what's going on. I don't have visibility of the data. So I think the next phase we'll see is around tools to help people understand and navigate appropriately around the services that are on offer to them, and also the data infrastructure on the back end, which obviously comes with a whole host of questions around, privacy and how that data is used and so on. But in terms of what is happening with that individual and how can that be tied together, because ultimately there is a risk in here that, there are risks that are emerging that don't get picked up because nobody has full sight of the data. So that can be dangerous on an individual level, but also collectively, that if we don't do that, that's where the costs and the complexity and the headache to individuals also starts to spiral out of control.
I thought there was a P11D question in here somewhere, and the questions move around as they vote, but please keep posting questions, please keep voting. But I thought it'd be interesting to sort of open this up to the audience. Are any of you seeing people withdrawing from PMI in your organisation because of increasing P11D costs? Just show of hands if there's...
Wow.
There's a few of you saying that is going up. Any reaction from the panel on that? Is that an issue that we're facing, or is that because employees don't understand the value of it? Is that a fair enough concern to have?
I think it is fair enough, but I think we haven't necessarily seen it evidenced. I can only think of one or two employees who've come out. Some of my colleagues are here, and they'll know one of our colleagues who did come out of the scheme and then immediately needed major back surgery. So he's now the story of fear amongst so no one wants to come out of the PMI scheme anymore. So we haven't really seen it in our London-based employees anyway.
Okay. I mean, certainly the PMI providers are very much highlighting the fact it probably costs you 3 or 4 times as much to get individually than you would through your employer, which people don't realise, and sometimes that could help. Just if anybody prefers to ask a question live and in person and would like to put their hands up, just very welcome to.
There's one in the back there.
Where's our microphone? There's one right at the back, and then I've got one in the middle, and then I'll come back to Slido questions.
Hello. Just on the PMI piece, we had a significant increase on our PMI this year, and it was communicated to all employees, and we were expecting quite a drop-off. We didn't. We actually had people join. But I think it's interesting how you communicate the cost. It was... From a P11D point of view, it's £3.60 a week is what it's costing the employer. So we communicated that as it's less than a high street coffee, which makes people think. So I think it's how you communicate the cost increase to the employer and make them realise that actually what value they're getting from that makes a real difference. So a Big Mac, a Starbucks, those sort of things, just that communication bit really helps.
Thank you for that.
Yeah, there's a comment that's been made on here about helping people to understand the true value of what they're getting for a relatively little cost.
Yeah.
There was a question in the centre over here as well at this table. What comment?
Thank you. This has been predominantly a PMI conversation so far, which is largely a white-collar benefit. Most of the UK population is blue-collar. So what do you think about when you talk about medical inflation and that population, which is also the majority of my workforce?
Regina, you've probably got a broader workforce view.
Yeah, we do serve a lot of organisations who have, would be that retail frontline staff or, staff on the road and so on. It's a challenge because they are facing, we are trying to help them navigate and signpost their, whatever's available to them through the NHS. And they come back saying, I've tried this, I can't get something for X weeks. And I'm very concerned about the potential inequity this is starting to set up because from people who either relying on PMI or willing just to pay out of pocket because they're fed up. And that's just not available for everybody. So I think health inequity is going to be a big issue because that starts to come up. And the problem with it is obviously it's, of course, a sort of vicious cycle. If people end up dropping out of the workforce because of health issues, I think we've got a problem brewing here.
Mm-hmm. Don't have a solution.
Yeah.
I think that's probably a government level solution as well.
Yeah.
NHS, it's quite a big issue, but yeah, very aware of the inequality on that. So if anybody else, there's a hand up over there, maybe.
You mentioned earlier about the health ecosystem, which we've seen an explosion of sort of well-being providers recently, even out here in the stands today. How did you sort of go about selecting which services you wanted to offer within a defined budget when they've all got value and they've all got a good purpose in themselves?
Yeah, absolutely. And we were making eye contact, so I'll just assume I'll start. When I think about ecosystem, I'm also thinking about how are we telling the story to the employees, or how are we getting the information to the employees in a way that is not bifurcated. So maybe my definition was a bit misleading, but to your question, completely hear you. Right now, we try to select suppliers that are multinational. So if we can do something globally that is still impactful locally, that's going to be our first choice. If we are doing something specific for the UK, we have a number of different variables that we look at, compliance being number one, and then what is the service, how well is it supported, how do we get it to the employees. What I haven't seen yet is a way to bridge the app-verse that we have. So my phone has more apps on it that are related to benefit programs that my team owns than other apps. And that's not a cool experience, right? And so what I want to help think through, and we're doing this with our partners, is how do I get away from I'm going to this app for that, I'm going to that app to app, I'm going to these 3 health apps for similar questions, and that, I think, is where we need to go, is how do our suppliers interplay with each other? How do they work with technology that other companies may be bringing on to bridge the gap across? I think that's a question worth posing when you're talking to suppliers, what is their long-term technology journey and how are they coming along with things? It may be AI, it may not, right? We're at the very precipice of something that's brand new to a lot of us, and some of it feels very cool, and we'll see what happens. But I think that that's a critical question. And then I would just go back to the basics around compliance, cost, what are the services provided? Are they the right thing for your employees? And be careful of shiny stuff. Like, are we really trying to solve for the right problem or the right voice? Or are we getting excited about headlines that we're seeing across different industries or within LinkedIn? And what are we looking to really solve for with that? Open it up.
Yeah, and I would say, I'd love to say that I'd love to say we have a huge strategy and we can follow that strategy, but sometimes a provider will come along and address a problem that you don't know you even had. So ideally, you'd be solving a problem that you focused. But when we found out, for example, that how many women of menopause age were thinking about leaving the business, we think, hang on, we're trying to tackle our gender pay gap here, and we've got this problem of women at a senior point in their career leaving the business. We didn't know this was even a problem. What can we do to remedy that problem? So it's kind of being aware of problems, but yeah, it's not any. I feel your app overload pain. Not an answer as such.
No, but I think it will sort itself out in due course, because the markets talk about, the big insurers are talking about it, everybody's talking about it. Love the fact we've got so much choice, but it needs to be more manageable. Now, this one probably plays quite well to having 2 employers that are larger with well-paid white-collar employees, and I fully appreciate that's what we have on the panel. But the question has come up about having a health trust versus insurance, and it's something we did some research recently, and we just said to people, are you looking at this? And I think, a lot of people say we want to look at putting in a health trust as a way to manage costs. And I just thought, does that really work? What are the kind of things that you need to bear in mind? Is there going to be a shift in that direction? Is it always going to come down to size and being big enough? Is it worth it? Sam, I'm looking at you in the first instance, because I know you're the one that raised it.
I think it's right now we're at the point where we're putting everything on the table. We have a trust currently. Yeah, there's cost savings in that trust, but there may be cost savings in other areas. So for us, it's actually, let me give a little bit of background. We as a team for international benefits are only 3 years old at Microsoft. So up until 3 years ago, nobody was overseeing kind of what happened in all of the countries. And so we're doing a lot of, why'd they make that decision? And what we're doing through that process is really putting every piece of the benefit deal on the table and going, okay, does this make sense as part of the deal? And does it make sense with cost saving? And does it make sense with the narrative that we're trying to share? And we had significant increases in medical this year. And with a trust, we still had significant increases. Now, there is a tax benefit there, and that's great, but it doesn't outweigh the increases that we had. So we're ready to go, okay, let's weigh the ROI on all of these. We may come right back to the trust and go, yep, that's it. But we now have the right level of conversation with our finance partners to say, stay here, and here's why. Right now, we're kind of going, okay, I think we could play in some other areas. I am up for always question why you've made the choice that you've made and back it up with data and back it up with the right decisions. And if you move forward with something different, so be it. But yeah.
We've got 3 minutes, and there's a question that's just come in that I'm very keen to ask. Sorry, Anna, I was going. And it's the costs associated with lifestyle-related conditions are continuously on the rise. What preventative initiatives, if any, do you have in place to address these? I want to start with you, Marigela, and I think, Anna, you've probably got an answer to that question as well, so this is absolutely crucial.
The costs are rising, the affected population's rising. In the next couple of decades, 1 in 3 of UK workforce is going to be over 50, which is often, that's the cohort where you see these long-term chronic conditions start to kick in. So yes, there is a lot of stuff that can be done on preventative care. In fact, a lot of certainly the more severe symptoms are often preventable through lifestyle interventions. I mean, that's something that, not to focus too much on Peppy, but that's a big core part of what we do. I think the problem has been in doing it in a way which is engaging to people, which and keeps their attention and keeps them on that program. Because we know that sitting in your GP's office as a type 2 diabetic, having a finger wagged at you does quite frankly nothing. So this is where I think actually technology has a really interesting role to play in allowing people to engage with their lifestyle and whatever, track their nutrition, track their activity, check medical adherence. Understand also what some of the implications are, because I really wonder how much people really understand about downstream implications of long-term conditions up front, when they can do things to do that. But 100% should be part of the solution. Huge believer in that. And I think actually catching people in work is a great place to get them to engage with that, because traditional healthcare, it's just, for whatever reason, the psychology of it does not work as well.
Anything to add in the last minute that we've got, Anna?
Yeah, to keep it really quick, but yes, we try and facilitate healthy choices for people that can improve their well-being. Things like we are very fortunate we have an on-site gym, but it's also kind of making sure that people can make healthy choices. In the kitchens, it's free fruit, it's not free cookies. Lots of little things accumulate to enable people to make a healthier lifestyle choice that can then lead to better prevention of conditions. Yeah, there's lots that combine together, lots of different things, but yeah.
Thank you. I did put a bit of pressure on you saying, go on.
Summarise a lot of things really quickly.
But I think that's one we'll need to come back to, prevention rather than cure, because once you get to claims level, that's where the costs go up massively. Can we please say a very big thank you to our panel for the session. That went far too quickly, far too much to discuss. As I said earlier, we will be doing a whole summit delving into this in much more detail. This was a real skim across the top, massive change in this area. So ending the session, there's now 10 minutes before the next session starts. If you're staying for the pay panel, that's in here. If not, 12:10 in whichever room you're heading for. Thank you. Oh, and please, if you wouldn't mind rating the session, that would be invaluable. Thank you.